So today we're going to continue our conversation on dopamine, wrap up the end of that, and then start a conversation on serotonin, which generally don't tend to get too intimidated by folks, but this is Dr. Parker's area of expertise. So I'm really excited to see what additional notes he has on the serotonergic system, just again, because, you know, that's very much his focus of his research, and I'm sure he has just a wealth of knowledge on it. So I think it'll be a really fun, a real fun lecture, I think hopefully between the two of us. Okay, so I've uploaded the slides for both the dopaminergic and serotonergic. Hopefully this afternoon we get to histamine. We'll kind of see how the conversation goes this morning. They've been uploaded in both PDF and PowerPoint forms. So if you are a PDF person, they're available in that form as well. Okay, so yesterday we started talking about dopamine, the importance of dopamine in the brain. Again, it has such a wide variety of functions in the brain, you know, that are worth mentioning. It's so important for the reward system. I think a huge argument can be made for the fact that most of the decisions that we make in our lives are based off of dopamine reward-based the dopamine reward-based systems, whether it be our desire for food or for sex or for shelter or any of those like primary drivers kind of evolutionarily are very much entrained in our brain via the dopaminergic system. So in addition to just those motivational factors, another component of the dopaminergic system is its effect on motor function. And so when the loss of dopaminergic neurons happens, probably the most kind of the physical presentation of that would be in the deficit of those motor systems. And so where I'm transitioning that is to talk about essentially the disease state that we left off talking about yesterday, which was Parkinson's disease. So again, Parkinson's disease is essentially characterized or is a pathological condition as a result of the loss of dopaminergic neurons. And so here, this particular slide just basically goes over many of the characteristics and symptoms that are related to Parkinson's disease. You can see that again, because, you know, we started this discussion talking about how widespread in function the dopaminergic system is. You can see that there are both motor skill symptoms as well as non-motor skill symptoms that this image right here, I think, projects pretty nicely. And so things like rigidity, bradykinesia, posterior instability, again, these are all going to be your motor system symptoms. You can have vocal symptoms as well, tremors, walking or gait difficulties. And so I think the previous slide we talked about the difference between tremors, tics, and chorea. And again, those are all different symptomatic kind of presentations of the loss of dopaminergic neurons, specifically what we see in Parkinson's disease. In terms of non-motor essentially skills or presentations, you can see there's some mental or behavioral issues, and you can see them listed over here. Changes, personality changes, apathy, sense of smell can also be altered, and then gastrointestinal issues and pain as well. So again, this I think lends itself, one, to show you a disease state that can arise with the lack of the dopaminergic system, but also I think shows you exactly how important the dopaminergic system is to normal physiological function. And so when that is no longer present, you can see that there are some pretty large deficits there. In terms of the Parkinson's disease, this image here is just, I think, a really nice, just clear schematic of exactly what's happening, right? You have this cluster of dopaminergic neurons in the substantia nigra that project onto the GABAergic neurons in the corpus striatum. Again, that synapse is also mediated through acetylcholine. And so you can see here, this is a normal functioning brain, but in a Parkinsonism brain, you lack those dopaminergic neurons. And so you're losing that circuitry in that case. The loss of the dopaminergic neurons, in terms of characterizing why is there this specific loss for this cell type, I don't think has been super clearly realized, but there has been shown that the things like the impaired degradation of proteins, so you've got proteins that are getting built up in those cells, you have aggregation, you have these alpha-synuclein clusters as well, oxidative stress, mitochondrial damage, inflammatory cascades, and eventually apoptosis of those dopaminergic cells. So you can see kind of how there are kind of a multitude of different cellular functions that get disrupted in these cells that lead them to eventually go into apoptosis and go into cell death. So I guess in terms of kind of why does Parkinson's arise? Like I talked about yesterday, often when researchers are studying Parkinson's disease kind of classically and historically, they've used MPTP because that selectively kills dopaminergic neurons. So, scientists could study kind of the pathogenesis and the downstream effect of the loss of those dopaminergic neurons, but really couldn't, I think, mimic the upstream factors that would lead to the selective loss of those dopaminergic neurons. So in the last, we'll say 20 years, we've been able to isolate more and more genetic factors that are related to the onset of Parkinson's disease. And so you can see some of those genetic factors here. So there's been genetic factors or mutations in the alpha-synuclein gene, the leucine-rich repeat kinase, the UCLH1 autosomal dominant, a Parkin gene. Again, these are all genetic, factors or SNPs or polymorphisms that have been observed sometimes, in the population. Then the researchers kind of work backwards to characterize exactly what those polymorphisms or SNPs are doing in the cellular way, in the cellular, I guess, paradigm. So sometimes there are animal models that are generated with these types of genetic mutations, and then they can essentially start to look at how the pathology kind of progresses if an animal is carrying one of those genetic mutations. I guess we covered a lot of this slide yesterday, but we did talk about some of the protective kind of environmental choices that can be made: smoking, coffee, anti-inflammatory drugs. The smoking, you're basically activating nicotinic receptors, and there could be a role of that, and ultimately that's part of the protective factor here. Anti-inflammatory drugs and high serum of uric acid. And then increased incidence is seen in certain types of professions, things like teaching and healthcare and farming. So I guess we did kind of go over this slide, but it's worth kind of just repeating, hopefully get some other little nuggets in that presentation. Okay, so as we're talking about Parkinson's disease, oh, yes, Rebecca.
All right, so I was just wondering, have they seen increased instances in people with substance abuse issues, since dopamine is so tied into a lot of addictive behaviors?
I guess it would depend. I guess it would depend on the type of addictive behavior and the type of drug. So if you're, let's say, ingesting a drug that maybe overstimulates the dopaminergic neurons in some way, that would possibly lead to cell death, that's, I guess, a possibility. I guess kind of the example that we talked about at the beginning of class yesterday was those individuals who had ingested that designer drug but had been contaminated with MPTP that caused the selective loss of dopaminergic neurons. But again, Keith, I'm always going to kind of refer to you. What do you have any insight here in terms of other addictive drugs that are being overconsumed that affect the dopaminergic system?
Not really, although in some cases it may actually be protective in the sense of stimulating more dopaminergic character than you would normally find. So I could see that cutting in both directions. One point I would like to make, though, and thinking back just a slide or two, looking at that individual and the various sorts of things that can, there we go, that can go wrong. Up there on the upper right side, mental, I would really like to emphasize the importance of that. Often when we're thinking about Parkinson's and related syndromes, we're thinking about the muscle weakness, the rigidity, the tics and tremors, things like that, all of which, of course, are very significant. But sometimes you don't hear that much about the mental aspects of it, but they're significant. And the degradation of cognitive function and things like that is a really big issue in many folks that suffer from Parkinson's or related disorders. Thank you.
Yeah, I think though that your question, kind of going back to your question, Rebecca, about those addictive properties. I guess if you think about, again, it depends on the types of the drugs that are being used. So if we take the example of cocaine, right, that's blocking the transporter, that's prolonging the activation of dopamine in that system. So if, let's say, if somebody has early onset Parkinsonian symptoms, you have that possibility of almost treating those early symptoms by blocking that transporter, because you're extending the lifetime of dopamine in that synapse and causing, the existing receptors that are still there to be activated longer. So in that way, it's almost, it could have like a therapeutic type of action. Again, I'm guessing the incidence of that is fairly rare. Again, it's not highly prescribed just because of its addictive properties, but there's always kind of that interesting interaction when you think about any type of neurotransmitter in its lifetime in the synapse. Sometimes, in some instances too, if you have that particular neurotransmitter active in the synapse for an extended period of time, that will in some instances lead to post-synaptic downregulation of that receptor as well. So it's a very, I think, delicate balance when we talk about neurotransmission. And I see Keith again.
Yeah, I'm sorry to jump in there again. There was one thing I forgot when you talked about, increased incidence with respect to occupation and so on. That farming one is particularly significant because there's considerable evidence to suggest that exposure to pesticides is problematic as far as these neurodegenerative disorders are concerned. So that one had caught my attention, and then I forgot to say anything about it.
Yeah.
Okay, I'll stop.
No, I mean, that kind of relates back to a lecture that we had a while ago when you were talking about organophosphates and the roles that they have in blocking acetylcholinesterase. That the organophosphates are obviously a pesticide, and so it's important to think about when we are treating our foods with these toxins, and we're trying to selectively kill, let's say an insect or what have you. Individuals will always say that the poison's in the dose, but then also poison can also be in the repeated exposure. So even those low doses over an extended period of time can have super detrimental effects, because in some instances they're kind of aggregating over time and causing those longer term issues. So this might be an example of that as well, what we're seeing with the dopaminergic system. Whew. Okay, great question. Obviously, it kind of got us into another kind of area discussion, but okay, so coming back to Parkinson's disease, and in terms of the therapeutic approach, hopefully everyone has this slide memorized by now, because it's a pretty simple slide, but it makes a very important point. We're talking about treatment of Parkinson's disease. Obviously, there's a loss of dopamine, loss of dopaminergic neurons. And so it's important to recognize in terms of treatment strategies, you can't just treat an individual with dopamine, because dopamine does not cross the blood-brain barrier. However, levodopa does cross the blood-brain barrier. BBB is blood-brain barrier, just in case anyone has any questions. Also, just a quick, I know yesterday there was a couple confusions about some of the abbreviations that I was using. Almost all of the abbreviations that I use in my slides are also abbreviations that are found in the textbook. I try to, again, keep that as consistent as possible. So if you have a question on a slide, if you go to the abbreviations section at the beginning of the chapter, which the text does a good job of kind of running through, usually you can find the abbreviation there. So just in case you ever are going through the slides later and you're just like, oh, I don't know exactly what that stands for, that's one resource you can use. Okay, back to the slide. So levodopa does cross the blood-brain barrier via LAT, which is an L-amino acid transporter. And once it has entered the brain, it's decarboxylated into dopamine. I like this particular figure here just because it kind of does a nice job of comparing and contrasting levodopa entry into the brain. So we talk about how levodopa crosses into the blood-brain barrier better than dopamine, but if you look at what that percentage is in the absence of carbidopa, it's still a pretty low percentage. It's just 1 to 3% that gets into the brain, and then you have 70% of it metabolized in the gut, and then 30% of it essentially finding its way into the peripheral tissues. So on the next slide, we'll talk a little bit about carbidopa and what it does and kind of how it assists in this metabolism. And you can see that you're able to increase almost threefold the amount of levodopa that's able to make its way into the brain again by essentially preventing the breakdown of levodopa in the peripheral nervous system. Okay, so if we talk about the ADME of levodopa, it's rapidly absorbed in the small intestine, which we see here in this particular slide. The plasma concentrations are going to peak 1 to 2 hours after or the oral dose. We'll talk a little bit about dosing strategies of this particular drug because it changes over the progression of the disease. But like I said in the last slide, only 1 to 3% ends up altering the brain, entering the brain. So it's important in most instances that it's co-administered with a deep carboxylase inhibitor, carbidopa, that increases the half-life. And so because of that increase in half-life, more of it is able to enter the brain. And so like you saw in that figure, up to 3 times more of it is entering into the brain. And then finally, down here at the bottom, I've also included kind of the metabolism of levodopa, some of the enzymes that it's broken down into. You can see obviously it makes it to dopamine, and then dopamine is broken down into DOPAC or that HVA, and those are going to be essentially excreted in urine within 8 hours. Okay. So in terms of kind of application of levodopa and how it's prescribed, so the best results are really seen in the first few years of this drug. So it's by no means a cure. What you're doing is you're essentially kind of, you're able to compensate, I guess, and allow for dopaminergic signaling to still occur. But it's not necessarily going to be curative in any way. And over time, we're going to actually see a decrease in its efficacy because for a few reasons. One, you have tolerance that accumulates, as well as adverse effects that are going to accumulate over time in the usage of this. Really quick, somebody just asked if L-Dopa crosses the brain better than dopamine. When would we use dopamine? Dopamine would be something that you use to treat some certain cardiovascular issues. So hopefully Dopamine's going back here just a few slides. So an example of something you'd use dopamine for would be to treat like things like severe congestive heart failure, sepsis, and cardiogenic shock. Again, the application of dopamine there is going to be only short-term and it's generally administered via IV. So if you're administering dopamine, you would never administer dopamine for a central nervous system effect, but some of these peripheral, I shouldn't say peripheral nervous system, some of these peripheral body systems that are related and have dopaminergic neurons expressed, so things like cardiovascular, kidneys, and obviously not the pituitary gland, you would be able to use dopamine in those instances to do things like treat congestive heart failure or to alter renin secretion. Hopefully that answered your question. Okay, so in terms of, again, like I said, because it isn't able to, levodopa isn't amazing at getting into the brain, treating with carbidopa, co-treatment of carbidopa increases that. So some of the combination therapies that are suggested are kind of listed here. I always like including these on the slides again, future pharmacy students. I think it's good to know kind of the general range of the dosages of specific drugs. And so generally the beginning treatment strategy is 25 mg of carbidopa, 100 mg of levodopa 3 times daily. And then later, as the disease progresses, you kind of up it to 25 mg of carbidopa, 250 of levodopa, 3 to 4 times daily. And that's essentially based on the progression of the disease and the symptoms that this individual is kind of presenting. There are other, I guess, kind of generic names for this combination use. There are extended release levodopas that are available, PHAR-COPA. It's one of the more easier ones to pronounce. You can see kind of the carbidopa, levodopa distribution here. So it's kind of a combinatorial generic drug that dissolves in the mouth. And Stellevo is levodopa, carbidopa, and a COMT inhibitor as well. And again, that's going to obviously affect the breakdown of dopamine. And so if you're inhibiting that, you're not metabolizing it nearly as quickly. And so over here to your right is just kind of a nice rundown of some of the chemical structures of these, molecules we're talking about, dopa, carbidopa, and then indocapoid, which is going to be that COMT inhibitor. Okay, so other therapeutic targets. So as we're talking about the dopaminergic system, just recognize that we talk about levodopa as just kind of being I think, the most frequently used type of drug that's utilized in this regard. But every step in kind of the system of dopamine, you really can agonize or antagonize with a variety of drugs. And so here you can see an example of dopamine receptors and different agonists that are available for usage. Again, maybe that's not good to start kind of at the beginning, because really it should start down here in the periphery where you're trying to get L-DOPA into the blood-brain barrier. So here you have the COMT inhibitor, again, that's going to inhibit the breakdown of L-DOPA, and then carbidopa, which is also going to inhibit the breakdown of L-DOPA as well. So essentially you're hitting those two enzymatic proteins that are breaking down L-dopamine. So by preventing that breakdown, you're allowing it to obviously circulate through the system longer and increase its possible uptake into the brain. As we went over before, that L-amino acid transporter is how it enters the brain. And once the L-DOPA enters the brain, you see DOPA decarboxylase breaking it down into dopamine. And then again, if you're looking to extend dopamine's lifetime in the synapse, you can do that by inhibiting the enzymes that are breaking it down. So obviously inhibiting MAOB or COMT are going to also increase that lifetime of dopamine. And then your other option is to directly agonize your dopamine receptors. And so using these drugs, you can actually activate those dopaminergic neurons. Sometimes, it can be, it's difficult to treat with an agonist at a specific concentration, just because generally you've got a very subtle, you've got activity dependent release that's occurring. And so if you're kind of overriding that by stimulating with an agonist, you're not necessarily getting that activation that is a result of the activity that is happening kind of upstream of that. So carbidopa can't get into the brain, so that's why it works so well in this manner. Yes, so carbidopa is hanging out down here, essentially preventing the breakdown of L-DOPA. Yep. Somebody's like, that's awesome. It's like, yay, pharmacology. Sometimes it works. I guess I kind of ran through this image over here, and many of these drugs that we're looking at here, things like the agonists, bromocriptine, Pergoglide, you're getting a sense of kind of how they're used. The advantage, again, of agonists is that you don't require enzymatic conversion, but again, dosage can sometimes be a very tricky thing. You're getting kind of a general understanding of some of the dosages that are used here and some of the selectivity of those agonists, whether they're a D2 or a D1 agonist. So bromocriptine would be a D2, Pergoglide would be a D1 and D2 agonist, but is no longer available in the U.S. due to some side effects seen, such as valvular heart disease. Again, we kind of jumped back a few slides and talked about instances that dopamine would be used, and again, obviously heart disease would be one of them. Pramipexole is a D3 agonist. This is a monotherapy that's used for mild PDs. So there are some instances in which agonists are still used for Parkinson's disease. And again, just a few ADME notes about this particular drug. Roperol is a D2 agonist and effective monotherapy, again, general dosage here, and then increasing it over time. And so you're going to kind of see that sometimes a general theme here might be increased dosages or uses of these drugs over extended time, again, due to that tolerance factor that we talked about and some of the adverse side effects that arise over time. Rogaine is going to be delivered through a skin patch, and the advantage to this would be more continuous stimulation of the dopaminergic system. So again, this is kind of just a nice laundry list of different ways in which the dopaminergic system can be manipulated outside of just levodopa. But again, there are advantages and disadvantages to each. And so we'll see that, I think, maybe on this next slide. Yep. Okay, so it's also, as we're talking about therapies, I found this figure online and I just really loved it because, we have so many words on all these other slides. What I liked about this is it's very visual in showing you some of the adverse effects that occur in the possible therapies that you would prescribe for Parkinson's. So obviously with levodopa, you have a higher risk of dyskinesia, motor fluctuations, or dopaminergic dysregulation system. And then with agonists, you have a higher adverse effect of edema, somnolence, impulse control disorders, hallucinations, nausea, and fibrosis. So again, I think with any type of drug that you're trying to stimulate a specific receptor, there's going to be side effects to always be taken into account. And so it's important, I think, to think about mechanism of action and how how you're able to essentially recreate the endogenous signaling as much as possible. And if you're unable to do that, what some of the side effects that might occur because of that inability to recreate the endogenous signaling. I'm going to pause for a second because I think we're almost wrapping up the dopaminergic stuff. So does anybody have any content questions before I kind of progress onto our, man, time flies, onto our first concept check of the day?
I have a question.
Yeah.
Would you ever combine like a dopamine receptor agonist with the carbidopa and levodopa?
I think there I can't, I guess I can't say, and so I hesitate to just give you a quick yes or no answer there. The only thing I might say is that a lot of these agonists here are suggested monotherapies, and so I'm guessing that combination would not occur, but I'm not going to say that that's not a possibility. So monotherapy. Keith, I see you popped up. What's up?
I think you answered that nicely, Katie. One instance that I could imagine where it might possibly be used would be as you're transitioning off DOPA and onto one of the direct acting agonists, then you might have a time frame there in which you're sort of going down in concentration with one and up with the other. But these dopamine agonists are pretty powerful dudes. Bromocriptine, for example, which you know it is not used as often anymore. It used to be used a lot, but it's pretty adverse. It's an example of an ergot alkaloid, and the ergots were very prominent in the early history of dopamine. About the only things we had for a long time, but now there are more effective and milder agents available, so that's why you don't see it used as often anymore. So in those transition periods, I could imagine there might be a little bit of overlap, but other than that, I think Katie, you answered with monotherapy is the more typical.
And I was gonna, I haven't looked into this, Keith, but do you know if there are any positive allosteric modulators that are utilized for the dopamine receptors?
I'm not aware of it.
Okay. Just because, I mean, like speaking to that, just kind of increasing the existing selective release, you could basically kind of amp up that endogenous activation. So that's kind of, maybe I'll look that up over break. So hopefully that kind of answered your question. I think we'll, maybe I'll do a little bit more digging over break to kind of see what the therapeutic, I guess, strategies generally are in terms of the combinatorial treatment of L-DOPA with the agonists. Good question though. You guys have such great questions. Okay, so our first concept check question of the day. I was thinking this would come like 10 minutes into class, and it's not the case. Okay, so a 60-year-old man is diagnosed with Parkinson's disease. So what is levodopa and how is it used in the treatment of Parkinson's disease? Hopefully that's a gimme question. What other drugs can be administered with levodopa? Again, hopefully that might not, given the conversation we just had, might eliminate some of the drugs we just discussed. And what are the adverse effects of levodopa that might affect this patient? But we just discussed a little bit of that. And what other drugs can be used for the treatment of PD? So I feel like these are all questions that we just kind of addressed in the last few slides, but I'm going to pause because maybe your mind wandered there for a few minutes while we were going over the last few slides. So if you want to just kind of write out in your notes just some of these answers, if you want to private message me some of those, I'm going to just give you, we'll say 3 to 5 minutes to kind of answer these questions. If you have any questions, feel free to shoot me a private message. I'm not speaking. I was just pausing. I actually had a student ask about the dopamine, L-dopamine dyskinesia. So one of the progressions that can occur with dopamine treatment. So if you have not had an opportunity to work your way through all of these essentially questions, I will be posting. If not, I don't know if this is already included. I think maybe in the version that I did post, because I think it had included all of the images. So I think the answers are actually included in the PowerPoint that you might be looking at. But in terms of kind of outlining some of these answers, again, I think it's just a nice capstone review of the conversation we've been having. Again, what is levodopa and how is it used in Parkinson's treatment? Again, it's a precursor to dopamine. We've talked about that extensively, how it's able to cross the blood-brain barrier. It's often, we'll talk about, I think, in the next question, essentially the drugs that are administered with it. It is able to cross the blood-brain barrier via that the LAT transporter, and then is converted to dopamine by decarboxylation. So this is just, again, a nice, real quick summary of kind of levodopa and how it's used to treat Parkinson's disease. Is converted to dopamine, and then is able to carry out the function of dopamine in the central nervous system. Other drugs that are administered with levodopa, I should just do this. Are things like the carbidopa, again, that's going to prevent the breakdown of levodopa in the peripheral nervous system. And then other drugs that would be are the inhibitors of the enzymes that would be breaking down the L-dopa once it is, or the levodopa as well. And so we saw COMT as well as with MAOA would be those enzymes that were blocking to prevent the breakdown of that drug. Some of what's nice about this explanation too is it kind of gives you some examples of some of the different drugs that are the generic names of some of the drugs that are co-administered, and also talks about some of the issues that arise with the levodopa carbidopa treatment. What are some of the adverse effects of levodopa? So if we go back to kind of that adverse effects slide, we saw dyskinesia is a possibility in terms of prolonged exposure to levodopa, and again, that could be a result of the tolerance. But again, you're altering this individual's endogenous dopamine, and so this is kind of a delicate balance between the dopamine that's existing, the dopamine cells that are kind of dying. As those dopamine cells are dying, it's obviously going to alter the body's ability to respond to levodopa treatment. So again, I believe this is posted as part of your presentation. So it's worth reading through kind of this longer explanation of levodopa. What other drugs can be used? So we just kind of went through our whole laundry list of all of the agonists. So there are a series of agonists that can be used for Parkinson's disease. Again, often they're used as monotherapies. I did some quick reading while we paused here for a second. There are instances where you do see co-therapies as some agonists with L-dopa. But again, as Keith kind of explained, those are often during transitional points. If a therapy isn't proving effective, then you'll start to have some co-treatments with the agonists and L-dopa. And then it also talks about MAOA enzymes and how blocking those can also prove effective in terms of increasing the amount of dopamine available in the synapse. So again, these are some pretty lengthy answers, but I do feel like they give you a great kind of overall viewpoint of exactly what's happening with Parkinson's disease, as well as the treatment strategies that are utilized to mitigate some of the symptoms. Again, none of these are going to be curative. The curative effect would essentially be to stop the progression of the loss of the dopaminergic neurons, but often here you're just kind of going around there and treating the symptoms instead by mimicking the release of the endogenous agonist, which would be dopamine. Okay, so we've essentially we have about 3 minutes left. I hesitate to start an entire new lecture. So I'm just going to pause here to see if anybody has any questions or concerns about, the material that you saw today, kind of wrapping up dopamine, or if you have any questions about kind of overall class structure, exam stuff, or anything really at all. Okay, well, I guess if nobody has anything, I'm going to let you go a few minutes early. We'll come back at 1 o'clock. We'll start our discussion of serotonin. Again, both the PowerPoint and PDF have been posted to Moodle page. That probably is going to force us to combine histamine and the endocannabinoids, which kind of bums me out tomorrow, but we'll really try to sneak and see if we can get both of those kind of covered in tomorrow's lecture. So again, if you have any questions or concerns, please feel free to hang out right now and chat with Keith and I, or send us an email as well. So thank you all for your time, and we'll see you very quickly here at 1 o'clock.